Good afternoon. While we're waiting for some people to join us, I'll go ahead and read the statements that are required for the course. We all will be using an audience response system, and to participate in this, you'll scan the QR code, which I think will come up here in a second. There you go. So if you scan that on your phone, then that will enable you to answer the questions. So we'll give you, I think, 5 ARS questions up front. Then we'll do the course. And then when you're done, you go back in, you'll get a course evaluation, and you will get credit for the course, and you'll see the answers and how you did with that. I think you'll have an opportunity also to answer again. The AUA states that all of our disclosures are known to you, and they are in the AUA website, and then we do have those included in our talk in the handouts. Please remember to silence your phones. They say no photos, videos, or audio recordings are permitted. We do highly value evaluations, and that's how we improve our course, as well as how we understand if it's worth doing the course again. So please fill those out. And I think you're also eligible for complimentary registration. There's like a drawing, so part of the participation in those evaluations allows you access to that. So thank you very much. Wait just a minute while everybody gets settled here. And then we're going to do the ARS questions first. I think they are streaming this online too, so if you see us like doing stuff on our phone, it's not just that we're answering, email. we're responding to like chat that's on the live stream. So just wanted you guys to be aware of that too. I didn't know if you're gonna close the doors or leave them open, but okay. All right. Well, if those of you getting seated, if you'll take a quick QR code scan on your phone, that'll allow you to participate in the questions. So I think they're at the bottom of the individual questions too, but we want everybody to participate in that if they can. Has everybody had the opportunity to take a picture of the QR code? Just raise your hand if you haven't, and I'll wait a second. Okay. So our first polling question, prostate cancer patients with germline mutations have been found to A, have more aggressive disease with BRCA1 as compared to BRCA2, B, be eligible for pembrolizumab, C, be present in about 11% of metastatic prostate cancer, and D, be present in 50% of castration-resistant disease. Is everybody able to see that on their phone?
Oh, there it goes. It's just delayed.
That's me. I got to click, I guess, to get you in. There we are. So those of you just kind of joining us, please take a picture on your phone of the QR code. That allows you to participate in the polling questions that we have. Okay. Polling question number 2, somatic testing performed in a patient with metastatic CRPC following progression after docetaxel and abiraterone reveals microsatellite instability. The patient is now eligible for, and the agents are A, lutetium, B, rucaparib, C, enzalutamide, and D, pembrolizumab. All right, polling question number 3. A 61-year-old otherwise healthy man complains of back pain and is found to have a PSA of 226 and greater than 5 bone lesions in the lumbar spine and bilateral ribs. A prostate biopsy confirms high volume Gleason score 8 disease. CT imaging also reveals pelvic and retroperitoneal adenopathy. Best overall survival has been shown with A, ADT plus denosumab, B, ADT plus abiraterone, C, ADT plus docetaxel, D, ADT plus cabazitaxel plus abiraterone, and E, ADT plus docetaxel plus enzalutamide. So of those choices, which is the best survival? Okay. And question 4, a 67-year-old man with a rising PSA on ADT despite castrate T levels has a doubling time of 18 months. Based on AUA guidelines, management should include A, darolutamide, B, sipuleucel T, C, abiraterone acetate, D, observation. And our 5th polling question, a 70-year-old man with metastatic CRPC has worsening back pain requiring narcotics. He's completed 6 cycles of docetaxel, but now his bone scan shows new uptake in the left pubic bone and thoracic spine. There is no evidence of soft tissue disease. Prior to docetaxel, he was treated with a course of abiraterone. The next best step is A, enzalutamide, B, radium-223, C, ketoconazole, D, sipuleucel T. Okay, now let me open up another set of slides here. Good. All right, so welcome everybody to our Advanced Prostate Cancer 2024 course, which is AUA, SUO Guidelines, and beyond. And I say beyond is because the data that comes out so quickly, the guidelines don't get amended that quickly. And so we try to include, as best we can, updated information on high-level evidence. And then, of course, when it is amended, we include it. I'm Dr. Michael Cookson from University of Oklahoma, and I had the privilege of introducing our panel here. See if our slides will advance. Maybe they will, maybe they won't. So this is our panel. Dr. Adam Keibel from Brigham and Women's Hospital in Dana-Farber in Boston. Whoops, now it really is advancing. We have Will Lawrence in the middle there from previously at University of Utah and now at Bon Secours, Greenville, South Carolina. And then Dave Gerard from the University of Wisconsin. So we gave, some of us participated in an all-day course yesterday on lots of things to do with this. So this is a sort of a 2-hour condensed version. So we will try to give you just the most important take-home messages in this time allotted. So I mentioned to you that the guidelines was published originally for advanced prostate cancer in 2020 and then amended in 2023. And here we are in 2024, needs to be amended again. So probably will be an amendment either this year or early next year. So when we come to you, there should be some more published guidelines in addition. This guideline really focuses on patients that have exhausted local therapy and now what's next beyond. So that includes biochemical recurrent patients who have failed local therapy, metastatic patients, castration resistant, both metastatic and non-metastatic. So it's a large swath of information. In 2024, unfortunately we know that prostate cancer incidence continues to increase, but really importantly is the fact that about 4 to 5% of these newly diagnosed cases are advanced or metastatic disease, and that's been increasing each year since 2014. So this course, unfortunately, is not going away anytime soon, because we have a problem and we need to be able to give these men the best chance at a long-term durable response. And in some, of course, we can't cure them, but we can at least control the disease for many more years than we used to in the past. But unfortunately, we'd love to say this course doesn't need to take place anymore because we have solved the problem. One of our 2 Nobel Prize winning urologists, Charles Huggins, realized the importance of this, even in the 1940s with the androgen responsiveness of prostate cancer and the fact that these cancers grow in response to androgens, and then deprivation results in at least a temporary state of remission for most men. And while over 90% of men with advanced prostate cancer initially respond to ADT, this is not going to be curative, and castration resistance often will ensue, followed by ultimate death if we don't control it. Number 1, male cancer. We're all quite aware of that. Around 300,000 cases in 2024 reported, and it remains the 2nd leading cause of cancer deaths in men, with about 11% of all the cancer deaths in men. So that's a statistic we'd like to see move down the list. We're going to cover the gambit of biochemical recurrence through the advanced metastatic and CRPC in our course today. So I'm going to start out with more of the biochemical recurrent and previously untreated metastatic patients. So this is the guideline statements that have to do with biochemical recurrence, and it says that when patients are being monitored for this, they're going to be informed that their PSAs are going to be checked. When in patients who PSA recurs after local treatments that are at high level or higher risk for development of metastases, so that would be people with doubling times, usually under 12 months. Those patients need to be followed with imaging, and then of course the preferred imaging is PSMA PET scans when they're available. We understand they're not available to all communities and to all patients, and so certainly conventional imaging is a second option for those men, but PET scan is preferred. When we talk about this, patients that have a rising PSA, they should be imaged and offered PSA monitoring, and then we know that if ADT is initiated in this setting due to rapid rise in PSA, rapid doubling time in PSA, patient concerns, etc., that this is an opportunity to do intermittent therapy in this setting. So this is not an uncommon problem. Somewhere between 20 to 40% of men will develop biochemical recurrence after local therapy, depending on their risk factors. There really hasn't been a lot of high-level data in this area, and the high-risk men are at risk for progression. In the guidelines, this trial is one of them that's noted, and that is the opportunity for intermittent therapy. This particular large trial was radiation failure patients, and they were randomized to either intermittent or continuous ADT. And the bottom line is that there really wasn't much difference in the outcome in these patients, and so that gave the opportunity to make that recommendation for intermittent therapy to give them a break. How that's done is not well prescribed. Most people go 8 to 12 months. If they're getting a good response, then can discontinue therapy, and then reinstitution of it, again, is more of an art than a science as to what level you would use and their anxiety as well as their preferences about it. However, there has been some data come forward, and some of you may have seen a little bit of this presented earlier today at one of the plenaries, but the EMBARK study that was published last year in the New England Journal was a study that took patients. So if you'd had surgery, your PSA had to be above 1, and if you'd had radiation therapy, your PSA had to be above 2 and rising. These patients were then randomized. Now there's no observation arm to this trial, so it was treatment in all 3 arms, and the treatment was either enzalutamide and leuprolide and placebo, or enzalutamide monotherapy. So there were 3 arms to the study, but no just observation arm. These patients had PSA doubling times of less than 9 months to be in the study, so it was enriched with patients that had kind of high-risk features by our standards. And then the primary endpoint is metastasis-free survival. So This is the Kaplan-Meier curves of the metastasis-free survival, and you can see that the yellow bar there is the patients treated with a combination of enzalutamide and leuprolide compared to leuprolide in the light blue, and there was a significantly improved metastasis-free survival in those patients treated with combination therapy over leuprolide monotherapy alone. This shows, in addition to that, some other benefits like PSA progression, time to the first use of an anti-neoplastic. Those were all secondary endpoints and significant. There is a trend towards survival benefit, but it's not mature enough to really report on that yet, so they didn't go as far as to say there's a survival benefit, but just the metastasis-free benefit. And then this looks at the 3 different treatment groups, and what they did was they treated them for like 9 months, and if their PSA went to less than 0.2, they too had the opportunity to go through a suspend therapy and observation. And so 90% of the patients treated with a combination were able to do that, which was higher than the other groups. And then the second bar graph there is how long could they stay on their intermittent therapy or stay off drug. And so for the combination patients, 20 months was what was seen on average before they reinstituted therapy, and that was superior to the other leuprolide alone or enzalutamide monotherapy, where they only had about 11 months. So something to keep in mind, that intermittent therapy in these high-risk PSA doubling time patients, less than 9 months, there was some benefit to combination of leuprolide plus enzalutamide. This study also reported on side effects, and of course there were side effects resulting from the combination treatments, but in general they were well tolerated, and the common drug interactions like fatigue and hot flashes were the most common. The enzalutamide alone arm is talked about because it offers the opportunity for sort of a testosterone preserving regimen. It would be used very selectively, obviously, and the results weren't as durable for those patients using the monotherapy enzalutamide. So now we'll kind of transition to metastatic hormone-sensitive or hormone-naive patients. These patients should undergo an assessment of the extent of their disease. So does it involve just their lymph nodes? Is it involving their bone? Is it visceral? In addition to that, it is encouraged, because of the way some of the trials have been reported, to kind of categorize them into low or high volume disease. And so I'll show you the charted definition for the most part in this, that symptoms or not should be also categorized and managed. The patients should be monitored in addition with testosterone check, PSA check at baseline, and then germline testing should be offered to patients. Some of them may have been offered the opportunity to get a germline test before they develop metastatic disease based on their risk, but overall report card on offering patients germline testing is still quite low in the United States, so we need to do a better job with that. This was some of the early data. We've known that extent of disease matters for a long time. Even in some of the early, like 1990 or 89-90 studies, Dr. Crawford and the SWOG group looked at the extent of disease, and that was back in the day when flutamide was being looked at compared to orchiectomy. And what it came down to was really the extent of disease really dictated how you would do, rather than whether you added an additional agent to the mix of orchiectomy. So it's been known, but the charted study really did a better job of sort of defining what that volume of extent of disease would be, and was kind of validated in their study, looking at whether you had 4 or more bone lesions with at least 1 outside of the axial skeleton and or a visceral metastases. That would be kind of the high volume definition. This is from the classic Pritchard paper in the New England Journal, but it's just to emphasize that we should be testing for germline mutations in men with high-risk disease and in men with metastatic disease. Certainly that qualifies. The most common alteration is the BRCA2. There are other alterations. Most of the panels test about 16 to 18 different mutations, but that can have implications not only for treatment in the future for these patients, and we'll talk about that a little bit later, but it also has a cascade effect for relatives, so 50% chance of passing it on to their offspring, and women, for example, with breast cancer. So it can save lives well in addition to impact potential treatment for these men later. The germline mutations are seen in about 11% of patients with newly diagnosed metastatic disease. And if you kind of look at the castrate-resistant group, and includes some somatic changes, but can be as high as 25% in those patients. So in terms of what clinicians should offer, it's believed that ADT as the backbone could be LH agonist, antagonist, or orchiectomy is a first-line treatment. But then in addition to that, patients should be offered intensification, and that could usually is some sort of an AR-targeted therapy and or chemotherapy, and we'll talk about that. But new to the update was that 16 guidelines recommendation that said in selected patients, and because of the studies that I'll show you, were really enriched with de novo almost exclusively in one study and like 8% in the second study. Really that discovery of metastatic disease de novo was how those patients were done, and so that was what was recommended if you're thinking about intensification, which is the ADT, chemotherapy, plus an oral agent, and the two studies that we'll discuss here are abiraterone or darolutamide. So that was an amendment to the 2023 guidelines. So what we see is that adding additional therapy besides just Lupron alone or one of the LHRH agonists or antagonists alone, that we really, unless there's a reason why they can't receive dual therapy or perhaps triplet therapy, they should be offered those things. And so we kind of progress through those treatments. The kind of the starting point was the CHARTED study. I remember when castration resistance docetaxel was originally reported in like 2014, it had only about 3 months of survival benefit in castration-resistant disease. But this took it forward to newly diagnosed metastatic patients, and it really just compared adding docetaxel to leuprolide compared to leuprolide alone. And what they did subdivide patients into high and low volume disease, and it was powered for survival advantage. And indeed, adding chemotherapy did improve the survival of men in addition to ADT alone, and it was about 12 months on average. So that was remarkable when we think about the lackluster 3 months, a year on average of better survival. And then even more importantly, if you looked at the patients by that volume of disease, in the high volume men on average, it was 18 months. So that was pretty significant compared to the average population. In the US study, they really didn't see much benefit in the lower volume patients. There was a second study. This was the STAMPEDE study, so more European. Again, same kind of trial design and same results with significant improvement in survival by adding docetaxel to the traditional ADT. And in their study, they did see benefit in both high and low volume patients. So the novel hormonal therapy studies were published, and there were 2 using abiraterone acetate plus prednisone in metastatic disease. And so the Latitude study showed significant overall survival advantage by adding a novel hormonal agent to the mix. And similarly, STAMPEDE showed kind of mirror results with improvement in survival, again arguing for why we shouldn't just use monotherapy in this population. Apalutamide, the TITAN study, also showed overall survival advantage by adding a pill to the mix. And so again, made it into the guidelines. And enzalutamide also showed significant improvement in 2 studies. The first one was ARCHES, which was originally just a radiographic progression-free survival, but later had overall survival. And then ENZAMET, which also showed overall survival, adding enzalutamide plus LHRH to the mix. So the triplet combination therapy, kind of the PEACE 1 studies, a little bit complex, but we're really just focused on the orange line there where they add standard of care, which then now we have said was shot plus the chemotherapy, for example, so LHRH plus docetaxel, and then adding to that abiraterone as the comparator. And what they found was that there was a significant improvement in these patients. Again, these were de novo metastatic patients with progression-free and overall survival advantage in this triple therapy arm. they didn't really see any diminution based on their subset analysis. So they looked at it different ways, and you can see those there, but really improved outcomes for all comers in this. And there was some toxicity, which would be expected. And there was liver and hypertension as call-outs for some liver toxicity, probably due to the combination of the docetaxel and abiraterone, as well as some hypertension. So you have to monitor these patients. Of course, anytime you use abiraterone, you're monitoring these patients for their electrolytes as well. And then this study here was the Aronson study, which, again, same concept, taking standard of care chemo plus ADT and then adding darolutamide or not to the mix, and then randomized it and found improvement in overall survival with the triple therapy. This is the study that, again, was highly enriched with de novo metastatic patients, so like 87% of those patients. Again, they've done subset analysis, and in their hands, no difference in outcomes if you were de novo or progressive patients, no difference in low and high volume, et cetera. But because the population had such a high amount of those de novos, that's where the AUA landed. This was previously there. I think I'm hearing that they're going to take this off the board now, but NCCN guidelines went so far as to say, don't just do ADT and docetaxel alone. And so it was either triple therapy or dual therapy with a novel AR targeted agent orally. I think they're going to soften this because really there is a role in some patients, and we haven't done the proper studies to really compare ADT plus chemo to ADT plus an oral agent. Those are underway, but until we have those, it's kind of hard to make that statement. This is just a compendium of the level 1 evidence we have for improved overall survival in men with metastatic disease when we take something besides ADT alone and add it to the mix, and I've reviewed those. I'm going to talk a little bit about the role of primary radiation in a minute, but you can see that doublet and triplet therapies are now kind of in that standard of care and should be considered for patients that are appropriate and not delayed. Now, here's the bad news. Some of this, the combination therapy, the dual therapy, has been known for quite some time. I told you docetaxel was published in 2014. But when they look into the real world and see what's really going on, only about 25% of men are actually receiving an oral agent, and somewhere in the range of 10 to 15% are receiving chemotherapy. So we've got some work to do. It would be sad to die of prostate cancer and never have the opportunity to receive that kind of treatment. It's not just urologists, so oncologists too are guilty of undertreating a lot of these men. So hopefully through initiatives and courses like we're doing, we will find a way. So the kind of proposed therapy would be at least dual therapy. If they're chemo fit and want to proceed with triple therapy, then certainly that's an option. And then local therapy can be added, and I'll talk about that in the time I have left here. In selected patients, and those are patients with low volume metastatic disease, there is benefit to offering primary radiation, radiation to their primary if they've never been treated, so that should be considered. We don't believe that there's really a role other than blocking the flare for the first generation anti-androgens anymore, and then we really don't have good data for monotherapy for metastatic patients, so you really shouldn't be on like an oral agent monotherapy. The data's not there. I'll briefly go through this, but this is the rationale behind. There were 2 studies, but the Stampede study in a subset showed the benefit of primary radiation in the setting of metastatic disease. So they took all comers and treated them with radiation regardless of their volume of disease. And in the entire study, there was no benefit, but there was progression-free survival benefit for the overall group. But when they took the group and subsetted them using charted criteria for low volume disease, there was significant survival benefit in men treated with primary radiation. So that is why that made it into the guidelines as a recommendation. So if you have a patient with newly diagnosed metastatic disease, low volume by charted criteria, there's a role for adding primary radiation to the mix. And that made it into guideline statement number 16. There's not really any high-level evidence for surgery in this setting, so we're doing trials, and one of those is listed here. It allows men to consider surgery as their option. It randomizes them into treatment or no treatment for their primary tumor, but if they choose treatment, they can opt in for surgery as an option in that setting. So for metastatic, newly diagnosed, chemohormonal therapy, certainly a standard of care with improved overall survival over ADT alone, probably best in high-volume men. More potent androgen targeting is a standard of care, improved over ADT alone. We talked about the role of triple therapy, particularly in those high-volume men with de novo metastatic disease, and treatment of the primary with radiation therapy improves outcomes and overall survival. So with that, in my pretest, I've run out of my budgeted time, and I will turn it over to Will Lawrence, my colleague, for the next talk. Thank you. And let's see, where are you here?
Thank you, Mike. Good afternoon, everybody, and again, welcome to the AUA's Advanced Prostate Cancer Guideline Overview course. See if I can advance slides here.
Sometimes it's a little slow.
You're just pushing the green button.
Yeah. And then if not, you can push the right side or the left side of that one.
Okay. So this guideline is, like a lot of the AUA's guidelines, is a collaboration between the AUA and the SUO. There was also input from ASCO as well as Astro also. So the aim is to provide clinicians with evidence-based recommendations in terms of, these are not my correct slides. Mike, how do I get out of this?
It's not advancing for you?
No, it's not the right slides.
Okay.
Sorry, everybody. I can use these if we have to. How are you able to go back to the? Go back to the file where slides are. So go back one more.
Try there, maybe.
I tell you what, let's do this. Do one of y'all want to do your talk, and I'll be sure to get the right slides put up.
Sure.
Okay.
Might have to go by the speaker ready room.
You're not able to add them on right now.
I cannot. You have to go to the speaker ready room.
All right. Sorry about that, guys. Let's. You want to go to yours, David? Which one do you want? That one.
Okay, well, moving right along, we'll try this deck. So, we'll be talking over the next 20 minutes about the manipulating the androgen axis and the recognition that the androgen receptor plays a major role in castration-resistant prostate cancer was really a major discovery that led to the development of a number of these drugs. It's important to realize that running an advanced prostate cancer clinic, you need to be aware of the space that the drugs are used in, new developments with these, as well as dosing and side effects, and we'll talk about these aspects. When we look at the current prostate cancer therapeutic landscape, you can see that initially many of these drugs were tried in much more advanced prostate cancer post-chemotherapy, and gradually it's been moved into the non-metastatic castration-resistant prostate cancer space. We're also combining it even earlier with metastatic hormone-sensitive prostate cancer, as you see here. So there's been this trend in moving this forward. Thus, it is more utilized by urologists. So really the overview of this talk is we'll talk about castration-resistant prostate cancer development. We'll talk a little bit about the androgen receptor and modifications that occur with it during this development. We'll need to understand new applications for these androgen axis agents, discuss some of the mechanisms and side effects, and then finally some of the new insights into androgen deprivation therapy and managing side effects. So as a case presentation, this is a 72-year-old who got radiation therapy and he was placed on androgen deprivation therapy for a biochemical recurrence. 3 years later, he developed a rising PSA while on continuous Lupron, and his PSA went from 8 to 21 over 8 months. His testosterone was appropriately checked and found to be at castrate levels. He now has new bony metastases with enlarged pelvic and retroperitoneal lymph nodes. So the question is really, what are stages and options for this patient? And clearly this is somebody who we would consider doublet therapy for. Now this is a discovery of the amplified androgen receptor in castration-resistant prostate cancer was really only discovered about 15 to 18 years ago, and realized that over 70% of these metastases have this amplification. I'm not going to talk about ligand-independent mechanisms since those are not really relevant to these drugs, things like cofactors, but we'll talk about how these cancers utilize the androgen receptor as an oncogene. One mechanism is amplification, or increasing the number of copies, and AR amplification is able to take advantage of a more limited amount of ligand to generate signaling. Furthermore, adrenal androgens are also produced, and those can be utilized by the androgen receptor. This is the mechanism of abiraterone by blocking that adrenal synthesis. The androgen receptor becomes more promiscuous. It develops mutations that allows it to bind alternative ligands such as glucocorticoids and metallocorticoids, other metabolites. And then finally, the androgen receptor can become modified, so-called AR variants, or ARV7 is the most common one. And this can indeed bind to its targets and stimulate androgen receptor signaling. Apalutamide, darolutamide, and enzalutamide are all focused on preventing binding and translocation of the androgen receptor. So let's start off with abiraterone, since that was initially FDA approved first. It's a drug that blocks the CYP17 alpha hydroxylase and C1720 lyase activity. So it prevents the formation of dihydroepiandrosterone, which is utilized as a steroid. Because of this, there's an increase in production of aldosterone. You see hypertension, low potassium, and salt retention. Furthermore, there is also an increase in cortisol production. ACTH is increased, so we use prednisone to offset some of those side effects. Abiraterone was initially utilized in the pre and post chemotherapy space for castration-resistant disease, and one can see here the improvement in survival that occurs in both of these randomized phase 3 trials. Furthermore, there are a number of side effects that we need to be aware of. I mentioned the fluid retention, hypokalemia, and hypertension. We can use our internal medicine colleagues to help us with that, but also be aware that there is an increase in a number of patients in these liver function enzymes. So the ALT and AST are often, these transaminases are often increased. So how do we minimize the side effects of abiraterone? Taken on an empty stomach, we take it with prednisone, 5 milligrams BID, and in some situations we can utilize once a day, again, to minimize the prednisone exposure. Liver function tests and electrolytes need to be checked 2 weeks after starting, and then monthly for the first 3 months. And for liver function elevations, one needs to hold this drug until these normalize and then restart at a lower dose. Finally, routine assessments for hypertension and fluid retention need to be performed, and often our internists can help with this. And remember, drug interactions, especially with drugs such as Coumadin, can occur. So abiraterone has been combined with androgen deprivation therapy in metastatic hormone-sensitive prostate cancer, and in that space improves outcomes. So which patients? It's FDA approved for men with castration-resistant disease before and after chemotherapy. It is also utilized for metastatic hormone-sensitive prostate cancer. We discussed some of the side effects with this, which are listed here. So which of our patients might be considered poor candidates? Well, individuals that are diabetic, gastric ulcers, or rapidly progressive disease or active infections, things that the systemic steroids would potentially make worse, would be poor candidates. Individuals that have significant cardiac disease or fluid retention may also be individuals we want to avoid treatment with abiraterone. And then finally, liver disease. So in addition to castration-resistant disease, these are some of the other choices we have in metastatic hormone-sensitive prostate cancer. So let's spend a few minutes now talking about enzalutamide and apalutamide and darolutamide. These are all similar mechanisms of actions. They're androgen receptor signaling inhibitors, and they were designed rationally to target the androgen receptor. It impacts multiple steps along the signaling pathway, include inhibiting binding of the androgens to the androgen receptor. It inhibits nuclear translocation of the androgen receptor, and then finally the association with DNA. Apalutamide and darolutamide, similar mechanisms of action, slightly different side effect profiles. So enzalutamide was used in the pre and post chemotherapy space. Indeed, improving survival is shown on the left here in the AFFIRM trial, and in the PREVAIL trial showing improvement in survival, but also other improvements in quality of life, or as shown here in radiographic progression. Some of the side effects that we see with enzalutamide include one of the more profound ones, which is fatigue. And again, one needs to be careful utilizing this drug in elderly patients. Another is hot flashes. There is some central nervous system absorption of this drug, and the seizure rates were slightly higher in several of the trials, so one has to be careful in individuals with pre-existing CNS conditions. Hypertension is also noted, and there was an increased risk of falls in these trials as well. Again, it may be related to some of the CNS effects. So how do we minimize the side effects of enzalutamide? We can dose reduce enzalutamide to improve that when we use concurrent CYP inhibitors such as gemfibrozil, which is involved in cholesterol. Enzalutamide may also affect serum levels of other CYP-inducing agents such as warfarin. One should consider dose reductions if there's profound fatigue or switching medications, and be careful about the seizure threshold as well. And remember, the enzalutamide has about an 8 to 9 day half-life. So when you're stopping this medication and restarting it, sometimes that has to be done for several weeks. So which patients? It's FDA approved in metastatic castration-resistant prostate cancer before and after chemotherapy. Also in metastatic hormone-sensitive prostate cancer. There are a number of side effects associated with this. And patients that are considered poor candidates would be those with a history of seizure, strokes, or falls, patients who already have significant fatigue and advanced age. So apalutamide has a similar mechanism of action, as I mentioned. There is some hypothyroidism that does occur with this drug, and a rash that can be fairly profound in some patients. Darolutamide may have less blood-brain barrier penetration, and so there may be slightly less fatigue or CNS issues with this drug. So, which of these androgen receptor pathway inhibitors should go first in advanced disease? Well, clearly for many of our patients, financial toxicity is an issue. Also, the clinical situation as well. An elderly patient with a significant amount of pre-existing fatigue may not be a great candidate for enzalutamide. We generally would want to avoid following one androgen receptor pathway inhibitor with another. If this is required, there has been some data suggesting that following abiraterone with enzalutamide, there is a slightly improved PSA progression versus enzalutamide versus abiraterone. But realize that this is generally not recommended, that we have other mechanisms, drugs with other mechanisms that we would better utilize in this situation. And then there are situations where rapid disease progression, significant symptoms, or visceral disease, we may consider more other options for chemotherapy, including platinum-based chemotherapy. So let's talk a moment about some of the adverse side effects associated with androgen deprivation therapy. Many of our patients have hot flashes, and these can be mitigated with such drugs as venlafaxine or gabapentin at a lower dose. Osteoporosis is important, and we'll talk a little bit about bone health. Fatigue, regular exercise can offset this. As far as one of the more concerning ones is this whole issue of cardiovascular disease. And realize that androgen deprivation therapy can increase cardiovascular morbidity. Part of this is due to increasing risk factors such as serum lipoproteins. Insulin sensitivity becomes more difficult to modulate in obesity with weight gain with these drugs. In HERO, which is a trial looking at the cardiac events with the GnRH agonist leuprolide and comparing that to GnRH antagonist relugolix, there was actually a decrease with the GnRH antagonists as far as major cardiac events. However, when we look at a lot of these pooled data that have looked very carefully at these randomized trials, there's really very little difference as far as cardiac risk factors between these two groups. And in a trial, the PRONOUNCE trial, which looked at this specific issue, comparing cardiovascular safety, there was really no difference in major cardiac events. So I think most experts at this point feel like the cardiac events are similar between these two classes of agents. The other thing, though, it is very important to remember is that we tend to assess our patients that are beginning androgen deprivation therapy with regard to cardiovascular side effects. And in a study of U.S. veterans just diagnosed with prostate cancer, about over 30% of them didn't get a comprehensive cardiovascular assessment prior to this, including such things as blood pressure, lipid profiles, blood glucose. Because of this, in 2010, the AUA and a number of entities recommended regular assessment of cardiovascular risk factors prior to initiating ADT, and furthermore screening and prevention for the patients on these drugs. I'll just mention briefly those patients that have a lot of hot flashes that are persistent yet need to be on androgen deprivation therapy. And one approach is actually using this drug. It's a patch trial. It's an estradiol patch, which was notable in that the number of patients with hot flashes on this was markedly decreased compared to just regular LHRH injections. And they had some comparable castration rates. There was no increase or decrease in cardiovascular events. So this kind of transdermal estrogen, and again, this is not DES, which actually increases thromboembolic events. Being transdermal, it avoids liver metabolism, and you miss a lot of those side effects. So this is one way to potentially manage patients with a lot of hot flashes. So the take-home points from this talk are a combination of androgen deprivation therapy with a signaling inhibitor plus or minus docetaxel, which was talked about. The triplet therapy are now standard of care in patients with metastatic hormone-sensitive prostate cancer. I mentioned these androgen signaling inhibitors. Again, they're preferred in patients who can't tolerate the systemic steroids that are associated with abiraterone use. Conversely, abiraterone is an androgen synthesis inhibitor, and it's preferred in patients that may have CNS issues, fatigue, or elderly patients. And again, monitoring and screening for these kinds of side effects are very important in patients receiving androgen deprivation therapy, and prevention is crucial. So I'll stop there, and where do we want to go from here? Keep rolling? Okay, very good. Okay, we're going to shift gears here and talk about sort of the next level of care with regard to chemotherapy. Okay, it looks like we're rolling here. So it's important for us as urologists to be aware of how chemotherapy is used in castration-resistant prostate cancer. And the earlier use of docetaxel for metastatic hormone-sensitive prostate cancer is an important indication for this drug. We're originally had used these drugs in metastatic disease, but again, you've seen this slide. We're now using docetaxel as doublet and triplet therapy for patients with metastatic hormone-sensitive prostate cancer. So what I'll do is talk a little bit about chemohormonal therapy in metastatic hormone-sensitive prostate cancer, talking some about side effects. We'll discuss choosing between docetaxel and androgen receptor pathway inhibitors and the role of triplet combination therapy, which is being utilized more commonly in this situation, although there are some questions about the space it should be used in. We'll talk a little bit about docetaxel and cabazitaxel in metastatic castration-resistant prostate cancer. We'll talk about mechanisms of action, comorbidities, talk about special situations to send patients directly into platinum, and I'll briefly mention a little bit about biomarkers for responses to specific chemotherapeutics. That'll be discussed a little more at length by one of our other speakers. So here are 2024 guideline recommendations for a patient with metastatic hormone-sensitive prostate cancer. ADT is an option in some patients that may be more debilitated, being used much less frequently in this modern era. ADT plus one of these androgen receptor pathway inhibitors as an option, or docetaxel. And then again, triplet therapy, plus or minus radiation, and we'll talk a little bit about this, maybe another option. And then finally, always keep in mind that patients with oligometastatic disease, hormone-sensitive, ADT plus radiation is an option. So, as was mentioned, the number of patients presenting with metastatic hormone-sensitive prostate cancer is actually increasing. And just using androgen deprivation therapy alone, progression to castration-resistant disease generally occurs within 12 months with a median overall survival of about 3 years. So we can do better, and we actually are doing better with the introduction of doublet therapy. There are a number of phase 3 trials, which we've heard a little bit about, but realize that treatment intensification is something that is gradually expanding in the field. So just to remind you, thinking back to some of those pharmacology courses you took, docetaxel and cabazitaxel are microtubulin inhibitors. And as a result, they inhibit mitotic and interphase cellular functions. It was first applied in this charted study with androgen deprivation therapy, and it hypothesized that this combination may lead to an improved outcomes in patients with metastatic disease versus just androgen deprivation therapy alone. It was really a very striking study. The majority of times we see an improvement in therapy, it's usually 2 or 3 months. With high volume disease, this was on the order of about 17 months. With low volume disease, as Dr. Cookson mentioned, no overall survival benefit was seen. So how do we define high versus low volume disease? And it's important to realize with the advent of PSA PET imaging, this whole definition of disease is beginning to change a little bit. And it's something that we'll have to talk about. It's a lecture in and of itself. But for this study, using bone scan and CT scan, 4 or fewer axial metastases were defined as low volume disease. And this is a theme that you see in the use of many of these studies. Again, this is slightly different from what we term oligometastatic disease, which is usually 1 or 2 or 3 bony metastases. So these are some of the results from these phase 3 trials of androgen deprivation therapy plus chemotherapy. It's well established as a doublet therapy. But more recently, triplet therapy has begun to be utilized, and this is combining androgen deprivation therapy plus docetaxel plus or minus darolutamide. And in this study, the triplet therapy reduced the risk of death by 32%, and it led to improvements in overall survival, progression-free survival, and other clinical endpoints. The side effect profiles were fairly similar, although the fatigue was worse, as we would expect with darolutamide. The deaths due in both of these arms were similar. The Ariston's trial was for men with metastatic hormone-sensitive therapy. It improved overall survival. There was a very complex 4x4 arm trial termed a peace trial where androgen deprivation therapy and docetaxel was combined plus or minus abiraterone and plus or minus radiation. But just focusing on the abiraterone arms here, it improved overall survival, although there was some increase in grade 3 events with the abiraterone arm. So adding an androgen signaling inhibitor to docetaxel does improve overall survival, but it's important to realize it's likely overtreatment in many patients. There are increased costs with adding abiraterone. And furthermore, not every patient may be a good candidate for this. It requires them to be chemo fit. So choosing between docetaxel, an AR pathway inhibitor, or triplet therapy, all patients should be considered for treatment intensification. Doublet therapy was less optimal versus triplet, but again, we're currently in the process as a field of trying to optimize these choices. I think the approach will vary based on side effects. Patient comorbidities are huge. Docetaxel combined with androgen deprivation therapy is in some sense the least expensive. You're done after 6 cycles, so you just continue on androgen deprivation therapy beyond that. And again, as mentioned, you must be chemo fit. Conversely, androgen receptor pathway inhibitors, we talked about some of the side effects associated with these. So we'll talk, and again, this is just our guideline recommendations for 2024 for metastatic hormone-sensitive prostate cancer. So let's shift over now to metastatic castration-resistant prostate cancer. And this is a patient who developed a rising PSA after radiation therapy, treated with doublet therapy. PSA nadir'd and then began rising, and he has a very rapid doubling time at this point, associated with new bone pain, osteoblastic lesions, and new liver lesions, so visceral disease. So what are the treatment options for this patient? So this NCCN guideline page is actually a very useful page to have in your pocket because it really goes through each of the different criteria. This upper box here is patients who with castration-resistant disease who've not received any docetaxel or no prior novel hormonal therapy. On the right is patients that have received prior hormonal therapy and no prior docetaxel, which was this patient we just mentioned. And then here are patients that have essentially received both. And in that situation, lutetium and other options may be beneficial. So this is a useful tool to keep at your disposal. So what are the general principles in this situation? prior treatments, as we saw on the previous slide. What options are available in my practice? Are there visceral metastasis for our patient we were just mentioning? There are. Is this patient a candidate for chemotherapy? And is there any evidence of small cell or neuroendocrine differentiation? Finally, it's important to perform genetic testing, and we'll talk a little bit more about that, to see if there are any targetable mutations. And then finally, what are clinical trial options for this patient? So back in 2004, so 20 years ago, docetaxel was really the first drug to show an improvement in survival in metastatic castration-resistant prostate cancer. It was a whopping 2 months of improved survival, but it led to its FDA approval. There are some comorbidities associated with this. Performance status is critical. One has to be careful about fluid overload due to third spacing when giving docetaxel. Dexamethasone is generally used with it. There are very obnoxious side effects such as peripheral neuropathy in these patients. One has to monitor liver function tests, and it can be an issue for diabetics. So who are the ideal patients? Symptomatic, so having pain. Some of those patients with potentially visceral disease, rapidly progressive disease, and we generally would use after one second-generation androgen pathway inhibitor, although, as mentioned, we now, in a patient who has more aggressive disease, would often consider triplet therapy, like the patient we're talking about here. So it's also been used in a neoadjuvant approach, and there was this phase 3 PUNCH trial, which used 6 cycles of docetaxel plus androgen deprivation therapy in patients prior to prostatectomy. And there was a modest improvement in biochemical free survival associated with this, but the cancer-specific survival was not significant. So what other options do we have? Now, many of you have heard of cabazitaxel. In the initial trial using this, it was compared post-chemotherapy or post-docetaxel therapy, and it demonstrated that it was associated with generally similar responses to using more docetaxel, but there were fewer adverse events, and we were able to use lower cabazitaxel studies with these phase 3 trials. More recently, it's been utilized in patients more earlier, basically pre-chemotherapy, and this is a study comparing it to abiraterone and enzalutamide versus cabazitaxel. And in this study, one can see that there was actually a better radiographic progression-free survival and overall survival using chemotherapy compared to that. So this suggests that it potentially does have a role earlier in the disease. There were, however, more significant issues associated with its use, and treatment was discontinued more commonly in these patients. So in summary, this is a drug we can use for docetaxel failures. It's less toxic at a lower dose. It's important that all patients have prophylactic growth factors with this. It's an option as initial chemotherapy as well after androgen receptor signaling inhibitor failure. And it's non-superior to docetaxel, and it may be superior to repeat ARSIs in this situation. And so this is a drug to, again, keep in mind. So we'll finish by talking about metastatic biopsy. And it's important to think about somatic testing in patients with more advanced cancer, not only from a diagnostic standpoint, but also for further genetic analysis. Patients that have visceral diseases, especially liver metastases, extremely bulky lymph nodes, low PSA in the setting of very high volume disease, and primarily lytic rather than blastic bone metastases. So androgen indifferent or neuroendocrine cancer is becoming something that we're seeing more of, given with the rise of AR-targeted therapies. There are a number of subtypes that have been generated, 5 of these. I'll only mention 2 of these. One is small cell carcinoma, and the other is adenocarcinoma with neuroendocrine features. And typically, these lack PSA secretion and are often AR negative. They express neuroendocrine markers such as synaptophysin and also chromogranin. We really end up treating these like small cell lung cancers using platinum chemotherapy. So what about biomarkers? We'll be hearing more about this, but alterations in DNA repair, one can use PARP inhibitors. And if mismatch repair gene defects such as MSH2, MSH6, one can use immunotherapy. I'll finally mention that AR variants such as ARV7 have been demonstrated to have resistance to enzalutamide or abiraterone in castration-resistant disease. This is a biomarker that has been utilized to try and figure out whether chemotherapy might be used first or whether these androgen receptor signaling inhibitors. I would say this assay is being used much less in this modern era, given the fact that we're moving more towards triplet therapy for many of these patients. Performance status is really an important aspect in these patients, and just to remind you all that the ECOG performance status is something that is utilized. So a patient who's a grade 1 has some light work restrictions. Grade 2 is ambulatory and out and about more than 50% of the time. And again, this all goes to all the way to ECOG grade 4, where they're completely disabled. So again, this is important when you're describing your patients in your clinics to have this. And then finally, this is a nomogram that looked at predicting chemo-naive patients. And it takes into account many of the things we think about with regard to survival and response. This includes how much in the way of pain medications they're using, LDH, the disease site plays an important role, lymph node only, or bony, or visceral. Performance status, you can see what a major impact that has on survival. And then these are some other various blood tests looking at albumin, nutrition, and things like that. So as far as take-home points, treatment intensification is associated with overall survival benefit and should be offered to eligible patients. In patients planned for upfront docetaxel, the addition of abiraterone or darolutamide as triplet therapy is associated with overall benefit. Docetaxel is a first-line chemotherapy for metastatic castration-resistant prostate cancer, generally used after oral inhibitors, and one needs to think about this in more rapidly progressive disease. Cabazitaxel is also a first-line option in metastatic castration-resistant prostate cancer. And there are new biomarkers we have, which again make the rationale for getting genetic testing an important thing to think about in these patients. And then finally, ECOG performance status and comorbidities can help us as far as guiding selection in patients considering treatment. So I'll stop there, and thanks for your attention.
All right, back for round 2. Sorry about that hiccup. It's not advisable to download the incorrect slides. Okay. So the point of the AUA guidelines is to provide clinicians, urologists, whoever's taking care of advanced prostate cancer patients with evidence-based guideline recommendations according to the different disease categories of advanced prostate cancer. And when we say advanced prostate cancer, like Dr. Cookson explained earlier, we're talking about anyone who has exhausted local therapy and then has progressed on. So for example, if someone has a radical prostatectomy, they have a biochemical recurrence, they then get salvage radiation therapy, and then they have a secondary biochemical recurrence. Now that patient fits into the advanced prostate cancer space. Also those that present de novo with castrate-sensitive metastatic disease. And then obviously this group of patients we include in the guideline are the castration-resistant patients as well. So a couple key definitions, and you've heard us talk about these already, but I want to spell out a few things. So when we talk about a biochemical recurrence after prostatectomy, the AUA defines that as 0.2 or higher. In terms of after radiation therapy, it's the Phoenix criteria, which is defined as nadir plus 2. When we talk about castration-resistant disease, it's at least a PSA of 2 that's rising in in a castrate state, which is defined as a total testosterone of 50 nanograms per deciliter or less. You're going to hear me talk a little bit about PSA doubling time and how do we calculate that. You need at least 3 values that should be 4 weeks or greater apart to accurately assess a doubling time. And then you've heard us talk about high volume metastatic disease. Well, that's when we talk about that in this guideline, it's based on the charted definition, which is either any visceral metastases or at least 4 bony metastasis, with one of those not being in the axial skeleton or the pelvis. So that's the charted criteria for high volume disease. And if we talk about high risk metastatic disease, that's the latitude definition, where you have to have at least 2 of these 3 factors: a Gleason 8 or higher, greater than or equal to 3 bone lesions, or visceral metastases. So I think we all know that the treatment of advanced prostate cancer patients really requires a multidisciplinary team. My opinion, and hopefully a lot of yours, is that the urologist should still be the quarterback of that team. Obviously, we need to involve medical oncologists. There's an expanding role for radiation oncology input, even in the face of metastatic disease, and then there's a whole host of other team members that are needed. Genetic counselors, we need pathology, we need radiology, we need palliative care for all the symptomatic pain care of these patients. So it's a real team approach that we need to set up within our institution to help take care of these patients. But I do want to stress that the urologist should be the point person in handling these patients. So I'm going to go back to some of the early initial guidelines. And one thing I know Dr. Cookson mentioned earlier, the importance of, if you see an advanced prostate cancer patient and they present with de novo disease, or even sometimes you'll find someone that's progressed that doesn't have histological tissue, it's important to still get a biopsy, whether that's of the primary site or of a metastatic site. You also need to really look at the patient and look at their overall estimated life expectancy. What is their performance status using ECOG, like Dr. Jared explained? And then what type of symptoms are they having? Do we need to go ahead and worry about pain control? Are they having outlet obstruction issues? And so there's the symptomatic approach that we need to take at first. So the 4 disease states that we break this guideline up are number 1 and 2. Those are the ones Dr. Cookson provided the guidelines for. And then I'll focus on 3 and 4. So 1 and 2 is the BCR patient. Number 2 is the metastatic hormone-sensitive patient. Number 3 is the non-metastatic castration-resistant prostate cancer patient. And then the final state, the last one I'll talk about, is the metastatic CRPC patient. So let's start with that disease state 3, the non-metastatic CRPC patient. So the guideline recommends that if we're following these patients, we should be checking serial PSAs on them every 3 to 6 months, and then conventional imaging every 6 to 12 months. So here are the 3 guideline statements related to that. Now, it is very important to calculate the PSA doubling time in these patients, and typically, and I'll explain in a minute, that's going to help you decide who of these you should treat versus just observe. The highlighted guideline there, number 21, is one we added to the 2023 update, which said you can also use PSMA PET imaging, either conventional imaging or PSMA PET, and the expert opinion is that should be every 6 to 12 months when following these patients. And I think that's what more and more of us are doing, or utilizing PSMA PET rather than always just conventional imaging. So there are now three FDA-approved agents that we can use to treat non-metastatic CRPC patients. And Two of them have been, all three have been shown to provide metastasis-free survival, and one has shown an overall survival with longer follow-up. Those are apalutamide, darolutamide, and enzalutamide. So very quickly, I'm going to go through each of the trials that led to the approval of these drugs. So the first is the Spartan trial, which tested apalutamide against placebo and showed a significant metastasis-free survival benefit in patients with non-metastatic CRPC. The Artemis trial was the one involving darolutamide versus placebo, and again, a very similar impressive metastasis-free survival benefit. And then the Prosper trial was where enzalutamide was tested against placebo. Now, in the initial reporting of this that was in the New England Journal, follow-up was only out to about 42 months. With another 2 years or so of follow-up, it did show a overall survival benefit with patients with non-metastatic CRPC that were treated with enzalutamide. And obviously all of these patients are also on standard androgen deprivation therapy, typically with leuprolide. So now let's transition to that fourth state, which is the metastatic CRPC patients. And in initially assessing these patients, it's recommended that they all have PSA, testosterone, LDH, hemoglobin, and ALK phos. Some of these other ones are things that you could plug in the nomogram that we saw to help give prognostic information on these patients. It's very important to assess them for any disease-related symptoms, whether that's bone pain, outlet obstruction, etc. Again, you need to formally assess their performance status. And then traditionally, they've all had conventional imaging. We know that's transitioning quickly to PSMA PET. And then again, you've already heard a lot about the importance of germline and somatic tumor testing in these patients, and that's recommended by the guidelines. This is the same slide you've seen already, talking about ECOG as how we judge performance status. So guideline 26 states that in metastatic CRPC patients, without PSA progression or new symptoms, you should at least perform imaging annually. So if these CRPC patients are going along, they don't have any new symptoms, their PSA is holding, it's not continuing to rise, then you still should think about imaging them at least once a year. And then in patients with disease progression, whether that's symptomatic, hey, I have new bone pain, or it's increasing PSA, that have previously received treatment, specifically previously received docetaxel, you want to consider getting a PSMA PET in those patients, especially if you're going to treat them potentially with lutetium. And we'll talk more about that later on in this talk. Very important, again, to get germline testing as well as somatic testing. And what we're doing, we're trying to look for any DNA repair gene deficiencies. You're looking to see if they have any microsatellite instability. What is their status? Is it high or is it low? And then that can have treatment implications in these metastatic CRPC patients. So the Pritchard study was mentioned earlier. It showed that about 12% of patients with metastatic prostate cancer will have a germline DNA repair mutation. There are studies that show even higher numbers of that. So again, very important that these patients have genetic testing. And as you know, it's not just, hey, send off and let's get genetic testing on them. There's a whole counseling part that needs to come with that. So very important to involve genetic counselors so they understand the potential impact of genetic testing on their personal situation, whether it's health insurance in the future, life insurance, those type things, and also the impact it could have on their family, what some of these findings might show. So there are a whole host of drugs that have been approved in this metastatic CRPC state. And I'm going to try to quickly go through each of these and just show you a brief slide of the trial that approved them. But the initial study was docetaxel back in 2004, which led to its approval, and then there's been an explosion since then of other drugs. So guideline statement 29, and this is this was in our original one and not updated recently, says that newly diagnosed metastatic CRPC patients who have not received prior androgen receptor pathway inhibitors should be offered ADT with abiraterone, docetaxel, or enzalutamide. And there was strong evidence to support that. You've seen this, but the mechanism for abiraterone is it's a CYP17 alpha hydroxylase inhibitor as well as a C1720 lyase inhibitor. It basically stops the production of androgens in testicular tissue, tumor tissue, and adrenal tissue as well. The two studies looking at abiraterone in this metastatic CRPC group was first Cougar 301, which was in the post-docetaxel state. It showed overall survival in that group, and then it was tested in the pre-docetaxel patients, and again also showed a similar overall survival with a hazard ratio of 0.81. Enzalutamide, you saw this slide earlier. And apalutamide and darolutamide have a similar mechanism of action. Not only does it block the androgen receptor, it blocks its translocation into the nucleus, and then also blocks it binding the DNA and impacting it. What led to enzalutamide's approval in this space was first the AFFIRM trial in the post-docetaxel chemo patients, and then later the PREVAIL trial. And in both of those, we saw a 3 to 4 month survival advantage in those patients. Moving on to docetaxel, the TAX 327 study that we've already heard about. Back in 2004, it was reported out with a modest, approximately 2.5 month survival advantage of docetaxel versus mitoxantrone, which was used at the time just because of symptomatic relief. And that's, at the time, docetaxel was the standard of care for men with metastatic CRPC. So moving on to other treatment options. In metastatic CRPC patients who are asymptomatic or have very minimal symptoms, you may offer Sipuleucel T. The IMPACT trial enrolled 512 patients that fit that category of minimal or asymptomatic metastatic CRPC, and what they found was an approximately 4 month survival benefit with this immunotherapy. Patients should offer radium-223 in those who have symptoms from bone metastasis and, importantly, have no evidence of visceral metastases and no lymphadenopathy greater than 3 centimeters. Basically, the Alsimca trial showed a survival benefit in almost all subcategories of patients, and what I've highlighted here is those had equal benefit whether they had received docetaxel chemotherapy or had not, but you see pretty impressive survival benefits in all the patients receiving radium-223. Again, it's very important to select those patients out. They're the ones primarily with bone disease, no visceral metastases, and no adenopathy greater than 3 centimeters. So the questions we always get are about sequencing, and we're learning more and more. They're just kind of broad principles or guidelines right now. If someone's been treated with an androgen receptor pathway inhibitor and they've progressed, well, now it's time to maybe try something different, chemotherapy, and vice versa. So look for things with different mechanisms, specifically when we're thinking about treating people with chemotherapy, whether it's docetaxel or cabazitaxel. Those with more advanced disease. So if there's evidence of visceral metastases, if there's rapid progression of disease, and then typically you want to think about a chemotherapy after they've received an androgen receptor pathway inhibitor. So moving on to cabazitaxel, in general, it was first approved as a second-line therapy for those who had progressed through docetaxel, but it can also be offered up front in those who have not received docetaxel chemotherapy. So we have the TROPIC study that led to its approval as a second-line treatment for those who had progressed after docetaxel treatment, and again, seeing about a 3 month survival benefit in those select patients. So what about molecular testing? We know that in our patients that have molecular testing that are shown to have a DNA mismatch repair gene defect, who have already received docetaxel chemotherapy, they have the option of being treated with a PARP inhibitor. If a PARP inhibitor is not available to those patients, say that have a BRCA1 or even an ATM defect, then they can be treated with cisplatin or a platinum-based chemotherapy. And then in patients that have microsatellite instability high status, pembrolizumab, a checkpoint inhibitor, is an option in those patients. And I'll briefly show the PROfound study, which showed olaparib provided approximately 4 month survival benefit over the control arm. And again, these were patients that had a DNA mismatch repair defect. So what about lutetium? Let's talk about that for a second. So clinicians, and this was added to the update of our guidelines in 2003, clinicians should offer lutetium to patients with progressive metastatic CRPC who have previously received docetaxel and an androgen pathway inhibitor, who have a positive PSMA PET scan. So that's patients that have already been heavily treated, so they've already gotten chemotherapy, and they've had an androgen pathway inhibitor, and now they have positive lesions on their PSMA PET scan. They are available to be treated with lutetium, which is a radioligand. It's a beta emitter that is attached. So this radioligand will attach to the PSMA receptors on the prostate cancer cells, and then the beta particles emitted and basically destroys the prostate cancer cell that it's attached to. This was the VISION trial. It was published in the New England Journal a little over a year ago. Showed overall survival benefit in the patients that got the lutetium. It also showed a delay in progression, or showed increased progression-free survival in the patients that were treated, and also a delay in the first symptomatic skeletal-related event. Now, one thing I do want to mention, it's not been published yet, but there's another trial that is specifically looking at lutetium in the pre-chemotherapy space. It's called the PSMA-4 trial, and they will be using the results of that trial, which I think have already been presented in abstract form, but just not published, to try to get an indication. But that is not approved yet in the pre-docetaxel space. So here's some information, or here's the website for more guidelines. I just want to recognize our advanced prostate cancer panel, as well as the AUA staff that helped us with this, and thank you very much for your attention. Which one do you want first? You want bone or?
Let's do bone first.
Bone first.
Thank you.
That was not working for me initially.
So I like to think they saved the best for last. Those of you who are walking out of the room are going to miss the best two lectures of this entire session. Of course, I'm having the same trouble with the slides as everybody else. Try this?
Use the mouse. Yeah.
Okay. Okay. So I'm going to talk about bone loss, not a very exciting topic, but important for your patients, okay? So elderly men already have a problem with bone loss. Androgen deprivation therapy also increases bone loss, and therefore we need to focus on it when we're taking care of patients who are on androgen deprivation therapy. Our patients all have these risk factors. They're older men. Obviously, previous fracture is going to be an issue. Low body weight. Many of these are elderly men that don't weigh as much as they did when they were younger. Current cigarette smoking and excessive alcohol consumption. Risk factors of potential relevance to our patients are the fact that they're already on hormone deprivation, also getting glucocorticoids, particularly the patients getting abiraterone that are also getting prednisone, and lastly, radiation therapy. The fact that there is a dose-related effect to androgen deprivation sort of shows how important this is. This is a study now almost 20 years old, but shows that patients that had a couple of doses or up to 4 doses had an increased risk of a fracture, but not nearly as much as patients that had 3 to 6 doses, greater than 9 doses, or underwent an orchiectomy. And these are both any fracture and a fracture requiring hospitalization, which is obviously the most important kind. Overall survival is better in men that have not had a fracture than men who have had a fracture when they're on androgen deprivation therapy. Now, how do we assess this? One of the ways that we assess it is by using a FRAX calculator. This is an online algorithm which has been released by WHO. You go ahead and you put in various different parameters that are important, like body mass index, and it gives you an output. And treatment is recommended if the risk of fracture is greater than 3%, or the 10-year probability of major osteoporosis fracture is greater than 20%. And this is really useful. A lot of people use this in their androgen deprivation clinics in order to evaluate patients. Important to get a bone density DEXA baseline, and again, pretty standard algorithm as to whether the patient's osteopenic, has osteoporosis, and then there are blood tests that can actually be useful as well. It's key to recommend in these men stop smoking, drink a little bit less, and weight-bearing exercise, which the older I get, the more I realize how important it is. Vitamin D and calcium, there are no specific recommendations, but the bone health guidelines basically say calcium about 1,000 milligrams per day in the 40 to 70-year-old age group, higher than that in the patients that are over in 70, and then vitamin D 800 to 1,000 international units per day. And the dose of the vitamin D is actually important. So this is a very nice meta-analysis. On the top, you have hip fracture and vertebral fractures, and you have a dose of 700 to 800 in the bottom. The dose is 400 international units, so less, 400 at the bottom, 700, 800 at the top. And the people at the doses at the top are associated with a risk reduction in hip fracture and vertebral fractures, whereas the lower doses don't really have an impact. What about calcium? This is obviously a little bit more controversial, though it seems to have faded a little bit in the Twitterverse and the lay literature recently. But calcium is important to bone mineral density loss. But there is conflicting data about whether it increases the risk of fatal prostate cancer. It is important to recognize that a lot of our patients are going to be getting denosumab and zoledronic acid, and you need to supplement their calcium because their calcium is going to get really, really low. So it's not only about maintaining a normal calcium, which is good for bone health, but it's also some of the side effects of some of the drugs we have on. The bone density agents that help support bone health are incredibly important. The concept is that, not rocket science, increased bone mineral density means a decreased fracture risk. Various different drugs here. These are the drugs not for patients that have metastatic disease, but the dose for patients where you're maintaining bone health, the patients that are getting osteopenic or osteoporotic because they are on androgen deprivation therapy. Zoledronic acid is a bisphosphonate. It's given as an IV infusion. It's the only one that's been demonstrated to improve fracture risk, have a benefit in metastatic castrate-resistant prostate cancer. That doesn't mean the others don't improve that. It's just they haven't been studied in randomized trials. It does have significant toxicity, which we're going to go over, predominantly around osteonecrosis of the jaw, hypocalcemia. I'm trying to emphasize that. And then if you're going to remember one thing, nephrotoxicity. You do not want to give this drug to people that have poor renal function. These are the guidelines. Obviously, they're in the syllabus, but basically you dose reduce for patients that have higher creatinine, and you infuse them slower, which will decrease the impact that it's got on renal clearance. Denosumab has become much more popular because you don't have to worry about that, right? I mean, all of us are in practice. The less I have to worry about, the better off I am at home, and the better I sleep. So this is a receptor activated. A receptor activator of the of rank ligand. It's easier to say. It inhibits osteoclastic-mediated bone destruction. So in other words, it stabilizes the bone by decreasing the amount of destruction. And it's given as an IV sub-Q injection. And it has the same toxicity. So even though it's a different class of agent and it works in a different way, stabilization of bone means there's going to be less calcium in the blood, and that can be bad for osteonecrosis of the jaw. So these are some pictures of osteonecrosis of the jaw. It's a terrible problem when people have it. It is very hard to treat. So the main way to do this is to prevent it. Before you put anybody on these agents, send them to a dentist. If they have any teeth that need to be pulled, have them pulled. Any root canal, have it done. Any dental work, have it done. Because once it occurs, it's really hard to take care of. These are the risk factors: cancer, radiation therapy, corticosteroids, poor dental hygiene. I mean, I can't believe it as a urologist. You have to instruct people to brush their teeth regularly, but you need them to have a good diet and take care of their mouths. Obviously, again, ethanol and tobacco use come up over and over again, which are incredibly important. How do you minimize this? I think I just went through this. Good oral hygiene, limited alcohol and tobacco use, as I said, dental assessment, and having them reassessed periodically so a small problem doesn't become a big problem. Yeah, if it develops on therapy, key thing is things like oral rinses, antibiotics, pain control, some limited debridement, though that can actually make it worse. I mean, as I said, the key thing is to prevent it. Some data that hyperbaric oxygen is actually helpful. Two options: which one should we put our patients on? Actually, this has been answered. There's a randomized trial. phase 3 trial with about 2,000 men. Kaplan-Meier curve actually looks like denosumab is a little bit better, but there was no difference in overall survival or time to disease progression. So if you're going to use this in order to help your patients, denosumab may be better, but there's nothing wrong with using zoledronic acid. The fact that the osteonecrosis of the jaw and the hypocalcemia is higher in the denosumab tells me that it's just a stronger drug, which is consistent with the prior study, the Kaplan-Meier curves I showed you. But there is some bad effects, and this is sort of new this year, associated with denosumab that I don't think people who prescribe it routinely sort of recognize. If you stop denosumab, the patient rapidly progresses to a bone mineral density that is in the pretreatment state, and they can develop essentially osteopenia and osteoporosis overnight. And one of the little tricks that some of the medical oncologists do is to put a little cap by giving the patient a dose of zoledronic acid as they're stopping the denosumab, and that sort of freezes their bone at that current state, and they won't have that the original osteoporotic state. Fractures decrease mortality. This is a nice study from SEER, roughly 50,000 men started on ADT. They got DEXA screening, fracture rates, bisphosphonate use, and survival. And what they did is they looked at this, and they found that only about 8% of these men actually received DEXA screening, which actually tells me that we should be doing an awful lot more of this. Of the ones who, the entire cohort, about 17% of them developed fracture. That's a high rate. I mean, almost 20% of patients. And older studies have shown exactly the same thing, so it's not going down as much as we'd like. If you got a DEXA screen, you were more likely to put on a bone-modifying agent, okay? If a DEXA screen was associated with a decreased risk in major fracture, so if you got the screen, you were less likely to have a fracture. And my interpretation of this, if you got the screen, more likely to put on an agent, less likely to get a fracture, and the overall survival was impacted by this. I mean, that's a 4% improvement in overall survival, which I think is pretty impressive. So these are the AUA guidelines. You should discuss this. You should assess the risk with the patient. You should put them on supplemental calcium, vitamin D, ask them to stop smoking, and do weight-bearing exercises. You should start them on denosumab or a bisphosphonate in order to prevent a fracture. And bone protective agents for metastatic castrate-resistant prostate cancer with bony metastasis should be used. So I'm going to skip past this for the time. So as part of this, important to look at bone agents. Okay, and we'll go through this. Some of this was already mentioned, so we won't sit on it for too long. So if a patient has metastatic disease, you can actually radiate the metastatic deposit. And this is a trial called the STOMP trial. They radiated patients that had metastatic disease that were outside of the cranium, not a huge number of them. And the endpoint they were looking for was androgen deprivation, not survival. And what they found is that Kaplan-Meier curve is telling you that the patient stays off androgen deprivation for a longer period of time. It's obviously good for their bone health, be off androgen deprivation. It's good for their skeletal muscle. It's good for them cognitively. It's good to be off androgen deprivation. And probably get a few less calls in your office because we all know patients love androgen deprivation. Oriel trial, very similar. The biggest difference there is they used conventional PET imaging, and they found exactly the same thing. That if you radiate these limited number of metastatic deposits, I'm not talking about a patient that's littered with mets. I'm talking about a patient that has a few metastatic deposits. You radiate them, they will be on androgen deprivation for a shorter period of time. Radiopharmaceuticals are increasingly important to understand in this space. So radium-223, it mimics calcium. Remember from college or high school, they had the periodic table, and radium was right there, right below calcium. It forms complexes with minerals and in areas where there's high bone turnover. So it doesn't actually attack the cancer. It goes to the area where there's a lot of turnover of the bone, and it goes ahead and delivers a alpha-emitting radiopharmaceutical. It's a high wavelength, so a lot of energy, kills the cells, but it doesn't get very far, okay? So it induces double-strand breaks in the cells, and the cell dies. There's a cartoon of it. You can see the radium-223 is attracted to the area where the bone is turning over rapidly and kills the cancer cells. This is a trial that was actually led to its approval. On the far left, you can see it's patients with symptomatic, I want to say that again, symptomatic castrate-resistant prostate cancer, greater than 2 in bone metastases, and no visceral metastases. Important around that. It's only going to be attracted to the bone. It's not going to take care of anything, other parts of the body. Randomization, and what they found was the patients who got radium-223 and the selected group of patients actually had an improvement in overall survival with a hazard ratio of about 0.7. And it also prolonged the time to the first skeletal-related event. So I spent all that time talking about bisphosphonates and denosumab, but really the most effective therapy to prevent people from getting fractures is to give them effective therapy, which kills the cancer cells. It's important to recognize that more is not always more. Sometimes more is less. We always talk about triplet therapy. I'm not arguing against triplet therapy, by the way. I'm just saying more is sometimes not better. So people have done a lot of work trying to add radium-223 to additional drugs. This is one with abiraterone, where they gave patients radium-223 with abiraterone or abiraterone alone, and the patients who got abiraterone alone did better, okay, by any metric you can look at. Symptomatic skeletal-related events, overall survival, bone fragility, all of these are telling us that abiraterone alone is better than the combination. We just went over the lutetium, so I'm not going to spend too much time talking about the VISION trial. Bottom line is the overall survival and the time to symptomatic skeletal-related event. Again, treating the bone, treating the metastatic deposit, made it less likely for the patient to get a fracture. Increasingly, they're doing randomized trials to try and add to lutetium. This is one called, it's a phase 2 called therapies, and it's lutetium versus carbazitaxel. So you have this patient that's got castrate-resistant prostate cancer, has failed docetaxel. Which one do you give? Standard of care is carbazitaxel right now. It might be lutetium in the future. This one basically shows that if you look at progression-free survival, the lutetium is better. But when you look at the overall survival, that's the curve on the right, absolutely no difference. So there's going to be a little bit of a dealer's choice in the future, I think, about which one we go to following the initial therapy. I think this is what was just sort of highlighted, the PSA-4 trial. This is roughly 500 patients, randomizing patients to an androgen deprivation. They've all progressed on an androgen deprivation, so the trial is put them on a new androgen deprivation, which we all know doesn't really work, versus PSMA, versus lutetium. And what they found with the endpoint being either a PSA progression or an improvement, in decrease in the size of the metastatic deposit, a clear benefit with a hazard ratio of about 0.43. So, bone-directed therapy, SBRT to metastatic deposits will keep patients off androgen deprivation. That's a win. Radium-223 is good with good performance status and known symptomatic bone mets. No known visceral disease, though they can have positive lymph nodes. And this is both in the pre- and post-docetaxel space. And lutetium PSA can be used in combination with novel ADT, can be used on bone, lymph nodes, and visceral mets, but only in PET-positive patients. Okay, so let's go to my next talk. And now I'm going to get the pointer over the mouse over there. This is tricky. I feel like the, did I go this way? There we go. Okay. Okay. Everybody still with me? So immunotherapy, targeted therapies, and future approaches. Okay? Promise I'll get everybody out of here on time. You're right, we have to click, that's the key, is to click on the
left side first.
There you go. So this is the overview. I'm going to talk about immunotherapy. There's already been some discussion at PARP, so we may go through that very quickly. And then future approaches, which I think is important. CRPC is the only immunotherapy that's really approved in this space. I say that with a little bit of hesitation. I'm going to go through some other things that aren't really immunotherapy, but are not really prostate specific. But I think it's important to know about it. Basically, the treatment takes an antigen, which is PAP linked to GM-CSF, puts it into antigen-presenting cells that have been harvested from the patient and taken to the company. They go ahead and the cell learns how to express these on the surface. They're then reinfused into the patient. And like magic, the cells go and they kill the cancer cells. Okay? And this is a therapy that works. Okay? The main this Impact 3 trial, a rather nice randomized phase 3 trial. And you can see the top curve is the patients who got the therapy, and the bottom curve are the patients who didn't get the therapy. They got something that we people have jokingly referred to as Frovenge. What they do is they freeze the product and they give it at a later date, which is obviously a little bit suboptimal. Clearly, there's a statistically significant benefit. The problem was there's no PSA response. And we all know PSA isn't important, but let's face it, when the PSA is still going up and the patient's like, what'd you do to me? It can make it harder to give the therapy. I think the results were probably even better than we think. So this is a rather nice analysis. The top, the blue curve and the red curve are the curves I just showed you before. The dotted one on the bottom is using some statistical modeling to say what it would look like if the patients truly got a placebo. So it's highly likely that it's even working even better than we think it is. These are the adverse events, okay? And essentially, you just got to remember it's like having the flu. How do you treat the flu? Tylenol, fluids, Motrin. So you can offer CYP-T to asymptomatic or minimally symptomatic patients, and this is both really any stage of the disease, though it does seem to work better the earlier you give it, probably because the immune system isn't quite as worn out before the patient's got multiple additional therapies. Okay, this is the nice part about giving this talk. I can talk about stuff that's going to happen in the future since it's future directions. So you hear a lot about CAR T cells and BiTEs. I zoomed in here so people would have an idea. On the left is a CAR T cell. Essentially what you're doing is you're molecularly changing the cell so it learns how to attack a tumor surface antigen. And you're permanently altering the patient's immune system, which I think is pretty cool. BiTEs are a little different. BiTEs essentially, they provide a link between the T cell and the tumor cell. So you infuse them, they don't last forever. It's like conventional systemic therapy in that regard. A lot of phase 1 trials out there, right, in prostate cancer. A lot of them around PSMA. So I think what the surprising thing is there's some recent data that shows that the BiTE that attacks this step 1 actually might have efficacy. So this is a phase 1 trial, and what you can see, the yellow is high dose and the blue is low dose. This is a waterfall plot, but what you can see is the vast majority of the patients had a drop in their PSA. That's the top one. And the bottom one is a change in the size of metastatic deposits. So that's pretty impressive. You know what I mean? So I think that's exciting. This is the most exciting data I've ever seen for BiTEs and for CAR T in prostate cancer. This data has already been shown. Metastatic disease is associated with increased risk in DNA repair. You'd say, well, what does that have to do with immunotherapy? Well, that's because pembro and immunotherapy is tied to defects in mismatch repair. So this is a study in colon cancer. Basically showed a nice waterfall plot that patients that had defects in mismatch repair has appeared to benefit more from immunotherapy, and the Kaplan-Meier curves essentially showed the same thing. And so people became very interested in using this in a variety of different malignancies. So this is the data that was used to get FDA approval. It's not a randomized trial. It's just they gave pembro to people that had defects in mismatch repair and showed, okay, that the patients did better that had defects in mismatch repair. The problem with these studies is only 6 of them had prostate cancer. And that's not a lot to hang your hat on. But it was FDA approved because of this. People have been very interested in using PD-L1 immunohistochemistry or expression as a way of deciding who can get PD-L1 inhibition in prostate cancer. And we have a bunch of different trials here. The bottom line is they're all negative. Okay? So this is an example of one. This is Keynote 641 given in castrate-resistant prostate cancer. Those Kaplan-Meier curves clearly overlap completely. And if you focus in on PD-L1 status, really, if anything, the PD-L1 unknown patients appear to do better than the patients that are PD-L1 positive or negative. This is in the metastatic hormone-sensitive prostate cancer, the thinking is, well, maybe the immune system is so wrung out, it's not going to work in castrate-resistant disease. And again, Kaplan-Meier curves show really absolutely no difference between the two. In fact, the placebo arm, I believe, the placebo arm is the top arm. So maybe the patients do better, if anything, if they don't get the pembro. So you can offer pembro to patients with mismatch repair defects or microsatellite instability with castrate-resistant prostate cancer. So not expression of the receptor. It has to do with whether or not they have defects in mismatch repair. How much time do I have left? When do we end?
10 minutes.
10 minutes? Okay. So I think the most interesting stuff that's going on right now is in PARP inhibition. So just so you understand the molecular underpinnings of this, okay? You give a PARP inhibitor to somebody who has, to anybody, okay? And what you're doing is you're shutting down one of the arms of DNA repair, okay? So it forces it into this double-strand break, so that the DNA, which has broken one strand, is forced to break both strands in order to fix itself, okay? And if you have a normal cell can fix it, okay? If you have a BRCA2 mutation, it can't fix double-strand break repairs. So the cell dies, synthetic lethality. So I think this study was presented. This is the PROfound trial using olaparib. The important thing is these are patients that have castrate-resistant prostate cancer. Okay, and what you can see is if you look at the top one, this is overall survival for all the patients, no matter what their status was, and the bottom of the BRCA1 and BRCA2 and ATM mutant patients. And what you can see is patients who have defects in DNA repair, specifically BRCA1 and BRCA2 and ATM in this trial, they're the ones that actually did very well. This is rucaparib. It's another PARP inhibitor. And in this phase 3 trial, very similar results. The top one curve are patients that had BRCA defects. Clear, I mean, that's such an obvious benefit. And the bottom is the ATM, not so much. So that's one of the reasons why maybe ATM is not as important as BRCA1 and 2 in identifying patients who are going to respond to a PARP inhibitor. We're going to come back to that again. Increasingly, what we're seeing is it in combination. And I don't think this has made it into the guidelines yet. So this is the Magnitude trial. These are patients who have castrate-resistant prostate cancer, okay? Good performance status, okay? And they've received taxane therapy prior, okay? And they have, they were stratified as to whether or not they'd seen an androgen deprivation prior, a novel ARI. They had a variety of different biomarkers, and they had two cohorts. The top cohort are the patients that were or DNA defect. They had defects in DNA. And then the bottom are patients that were sort of, you know, everybody else. And then they were randomized to niraparib plus abiraterone or placebo plus abiraterone. So on the left, you can see the progression for those that were had defects with a central review. And you can see there's clearly a benefit. On the right, you can see when you just limited to patients that were BRCA1 and BRCA2 mutants, and the benefit appeared to be dramatically more. This is a further follow-up. So here, the benefit was approximately, I want to say, six months in improvement in survival. And now with further follow-up, the benefit is now around 9 months. So you continue to see a benefit with this agent in combination with abiraterone over a long period of time, particularly in patients that are BRCA2 and BRCA1 deficient. This PROPEL, very similar trial, now using olaparib, essentially the same inclusion criteria, healthy patients, and they're being randomized to olaparib and abiraterone versus placebo plus abiraterone, and a very similar result. So on the left, you can see that the patients that had defects in DNA repair did quite well, separation of the Kaplan-Meier curves. In fact, I love the fact that they separate more as you get farther away. Patients in this study, they also included patients that did not have defects in DNA repair. The idea is that maybe the abiraterone made them BRCA-like, okay? And you can see absolutely no benefit in that patient cohort. The last one is this trial called TALAPRO. Very similar, again, inclusion criteria. They were stratified again by prior hormonal therapy and whether they had they had a defect in DNA repair, and it was talazoparib, I have trouble pronouncing it, and enzalutamide versus placebo and enzalutamide, rather large study with about 800 patients. So on the left, you see the patients that had defects in DNA repair, clear benefit. On the right, you see patients, you see where there was a defect in, not a defect in DNA repair, they were either did not have a defect in DNA repair or you didn't know if they had a defect in DNA repair. And I suspect that the benefit on the right is a product of the patients that are BRCA1 and BRCA2 and you don't know it yet being included in the patient population. If you knew the status of all those patients, my guess is that the benefit would go away, but I don't know that, okay? To date, there's no survival. I want to be clear about this. This doesn't mean there's no survival benefit. They just haven't followed these patients long enough in order to demonstrate that. I have absolutely no reason to think that they won't be very similar to the other studies. So PARP inhibition, first of all, you need to sequence the germline in the tumor to know whether or not the patient is going to benefit. And you have to do this in all your patients now. You really do, okay? DNA status matters. For PARP monotherapy, but BRCA1 and 2 patients are going to benefit the most, okay? I think in patients that have castrate-resistant prostate cancer, the standard is to use the PARP inhibitor on its own. The drug matters. They're not all exactly the same, and I think people are going to tease that out over time. And the combination therapy may make HRR status less important in patients that have castrate-sensitive or hormone-sensitive disease. So this is the actual recommendation. You should offer PARP inhibitors to patients with deleterious or suspected deleterious germline or somatic defects in DNA repair, for patients that have metastatic castrate-resistant cancer. And at the current time, I don't believe that the data on hormone-sensitive disease is made into the guidelines, but it will shortly. So the last thing, we're going to go through this very quickly. Integrating, I think the future, which anybody who's a urologist in the room needs to be aware of, is we're going to be integrating systemic therapy even earlier into our disease management, okay? So basically, end-stage disease, you give them systemic therapy, improves their life expectancy by 2 to 4 months. Metastatic disease, 12 to 24 months. I think I should probably update this slide to include patients that now have PSA failures and we don't have metastatic disease, because then we see an even further improvement. And the question I have and others have is, if you treat the localized disease with adjuvant or neoadjuvant therapy, will you actually cure patients that were previously incurable, or at least extend the improvement in life expectancy in terms of decades, 1 to 2 decades? Been shown in breast, colorectal, and lung cancer. There is a study out there that was highlighted earlier, the PUNCH trial, where patients were given docetaxel and hormone therapy and taken to the operating room or taken straight to the operating room. And this was, interestingly, did show no benefit in biochemical free survival, which was their endpoint. That was the primary endpoint. It did show an improvement in overall survival, but the real problem is there was significant toxicity associated with this. And so as a result, people just don't prescribe it. This is the paradigm that we've been using at our institution in collaboration with multiple other institutions across the country, taking people with intermediate and high-risk disease, randomizing these patients to systemic therapy, and seeing whether we improve both the likelihood of them being P0 and decreasing the likelihood and decreasing the amount of androgens that are actually in the tumor, with the idea that that will improve metastatic disease and presumably overall survival. So just for the sake of time, this sort of summarizes all those studies. We go ahead, we assess tissue biomarkers and intratumoral levels of testosterone and other androgens is lower in the patients that got more intense therapy. Less cancer in the specimen if you go ahead and you treat with more intensity. And it looks like that there's going to be better decreased recurrence rate. That's what we need to prove next. And I've been very fortunate to be part of a phase 3 randomized trial called Proteus, which we have data lock on now, and hopefully we'll be able to demonstrate whether it is or isn't a positive study in the future. I don't know. I'm not actually endorsing this outside of a clinical trial because, and those of us who do clinical trials know, many more clinical trials are negative than are positive, but I'm hopeful after the EMBARK data and the PRESTO data, which is another similar randomized trial, that we will actually prove that neoadjuvant and adjuvant therapy following radical or in the middle of radical prostatectomy will actually improve the survival of our patients. And this just shows the enrollment, which is outstanding. So CIP-T is the only FDA-approved immunotherapy. I think CAR-T and BiTEs are the future. I mean, just remember that. You don't have to know any of the data. Just know that when someone says BiTE therapy might be interesting, you can say something intelligent to your patient. Pembro for tumors with mismatch repair defects only. PARP inhibition for tumors with DNA repair defects. I think the future is very bright. I think we're going to see more and more new targets and more new therapies. Thank you very much.
All right, we don't have a lot of time, but if there's any questions for the panel, come on up.
Hi, I have actually two questions. Is there any evidence using couplet therapy in the neoadjuvant setting for radiation therapy for high risk, unfavorable intermediate risk, or gleasonate, prostate cancers?
By couplet, you mean like abiraterone, enzalutamide, along with?
Yeah.
Is this working?
Yeah.
I think it's working. Yeah, I mean, Stampede had a very, very good trial where they went ahead and did that, particularly in patients with lymph node positive disease. PSAs, I think, of over, I want to say 40, and Gleason 8, 9, and 10, and they showed that it improved the outcome if the patients got abiraterone and LHRH in combination with the radiation therapy. So I would
So
say
are you
the
doing
answer
that?
is yes.
Are you doing that for all your patients then who get neoadjuvant ADT? Or?
Patients that are in that very high-risk group,
Only the
yes.
high risk.
So if I get a PET scan, for instance, and the patient has positive lymph nodes, that's, in my opinion, the standard of care. Do you guys want to comment at your institutions?
Yeah, I mean, I think what you're saying is T3, T4, N1, locally advanced, high-risk people often get, that sort of regimen for about 2 years in combination with radiation. That's
What about just a guy
fair.
with Gleason 8, PET negative, going to get 2 years of ADT?
Yeah, I don't think the data is really supporting that at this point, but typically, exactly, the sort of higher risk node positive patient that will be giving an androgen receptor pathway inhibitor. Yeah.
And
Can I
sorry.
just comment? I think we've had a real shift in what Gleason 8 cancer is,
Right.
and not even 9. Like I see people all the time where they have a PET, they have an MRI, a focal biopsy, and it shows Gleason pattern 8 in like 10% of a single core. I don't consider that high risk, but every core showing Gleason pattern 8, I probably would consider abiraterone.
So I totally agree. So just a straightforward Gleason 8 is going to get 2 years of leuprolide in combination with their external beam radiation, or if you're going to do combination radiation. If you have T3 or T4 disease, so seminal vesicle involvement, or T4 disease, Gleason 8, or like Adam said, pelvic nodes, then those are the patients that get the doublet therapy with abiraterone and leuprolide, 2 full years plus their radiation.
And there have been some trials that are not randomized, but looking at like Formula 509 as an example, where they do like triple therapy and see if they can shorten it into 6 months of triple drugs versus longer duration of monotherapy or dual therapy.
Are there any evidence of using like circulating tumor DNA to try to predict which patients need more aggressive systemic therapy earlier?
There's a lot of investigation.
Yeah, yeah. There's a lot of investigation. I mean, one thing about circulating tumor cells, it's not really equivalent to getting a biopsy and doing somatic genetic testing, just because the sensitivity is not there, and they're not running a full panel as well. So, and you're not quite sure what you're selecting for too when you're pulling it out of the bloodstream. So. Right now, it's a good thought. I mean, can we use circulating biomarkers to, target patients that may need more intense therapy? But we don't have anything we can really hang our hats on regarding that right now.
Sorry, I have one last one. Is that okay?
Yeah.
In patients who fail radiation therapy, rising PSA, PET negative, do you feel compelled to biopsy the prostate before you do salvage therapy, like a cryo or something?
So guidelines were presented this morning by Todd Morgan, and they were pretty clear on that you should do a local biopsy before you treat for local failure after radiation.
Okay, thanks.
Can I just ask something that came up a while ago on that? Is we had a patient where they they got a PSMA PET, and it really lit up in the prostate. Would that person actually need a biopsy before you consider?
Currently, the answer is still yes. I mean, there are a small series out of Europe, some Germany, where they're doing even radical surgery without a biopsy based on correlation with PET and MRI imaging. We're not there yet. And, what would happen if you took out the prostate, no pathology was seen, bad outcome, that might put you at a risk you don't want to be in. So,
It's called prostate, prostate-specific membrane antigen. Cancer is not in that definition. So you see stuff like, I've seen patients where they're biopsy positive on one side and the PET is positive on the other. I've seen seminal vesicles light up on PET imaging and the pathology doesn't show anything. So
Yeah.
it's not really designed for local assessment of local disease.
Yeah, I agree with that. I mean, the imaging's, it's unbelievable. It's changing how we do things, but it's not perfect. We see positive ones. I mean, salivary glands, inguinal lymph nodes. You see bone that's, quote, positive that's really not. So I think you do have to be cautious.
but having said that, it sure makes the biopsy easier if you know on the right side in the peripheral zone correlates, you can know where to target to get your sample.
Yeah, I just mentioned also, we're all beginning to pick up, lung cancers. I've seen like 4 or 5 thyroid cancers. It's really remarkable. So it's not prostate cancer specific as well. So yeah, I agree that just get a few biopsies from that area.
I had one the other day where the radiologist read it and said, we think this patient may be having a stroke. Basically a PSMA scan. And they were. Not an active one, but they were having TIAs.
All right, any other questions? Don't forget, go ahead. And then don't forget to fill out your evaluation forms, and you may get a free registration next year, and we need your feedback, so thank you.
All right. So you mentioned the neoadjuvant ADT prior to prostatectomy and the clinical trials that are ongoing. Any data on functional outcomes and technical challenges intra-op during prostatectomy?
So yes and no. I mean, so the yes is, we've published stuff. The problem is that the patients have very aggressive cancer, so you're not doing a lot of nerve sparing and things like that on these patients anyway. I would tell you anecdotally that we do have a lot of patients that are on these trials that are potent where we spare the nerve on the side. I've done an awful lot of these surgeries myself. The surgery is not harder. I mean, in the day when they got 3 months of androgen deprivation, the surgery was demonstrably harder. I remember that. But with the more intense therapy and with the longer period of time, I think the prostate shrinks and sort of stabilizes. And so sometimes I find it's easier. I mean, this prostate's nice and small, and the nerves come off very easily. So if you're going to do nerve sparing.
Is that going to be reported in the trials outcomes?
Eventually, we collected a lot of data.
Yeah.
Okay.
And there are a number of phase 2 trials regarding this. I'll just say, Adam, we're running a series of phase 1-2 trials, 3 months of therapy, and it's easier in that subset. But you have to be selective, and digital rectal exam can really provide a lot of information. If you perform a digital rectal exam and it's fixed, firm, that's probably not an ideal patient for putting through surgery, because it's really going to create a lot of issues.
And regarding adjuvant therapy after that, does taking these neoadjuvant treatments exclude your ability to treat further later on?
The Proteus trial has both neoadjuvant and adjuvant, and that's on the basis of phase 2 data, where we extended the original phase 2 trials we did were just 6 months beforehand, and we got a good response, but we found that more intense, longer therapy was more effective, so we extended it on the other side. And we found in our phase 2 data that the patients were less likely to have a biochemical recurrence than quote-unquote historical controls. I'm not really sure what that means, but a longer therapy, I think, is going to be better.
Yeah.
Divided into neoadjuvant and adjuvant.
And if
Gave
you
them both.
you remember, almost all of the early neoadjuvant, we're just really looking at margins and not powered for anything beneficial like radiation oncologists did, and their studies were larger, more robust, and had better endpoints.
Yeah, but I think your point's a good one, because the question is whether neoadjuvant is superior to adjuvant.
Yeah.
And we don't know the answer to that, and that's down the road. We'll have to figure that out.
And we're not currently comparing these two.
So the reason why the neoadjuvant trials were chosen was because, number one, we'd like a more surrogate endpoint, which is to have eradication of the cancer in the prostate, because if we have to wait for the patients to be alive or dead, no company is going to be able to do that. And the second thing you had is patients really didn't sign up very much for adjuvant trials. You ended up putting them on radiation therapy trials afterwards.
Okay.
And so we didn't really have the opportunity to see how well this therapy was going to be working on its own. And so that was the rationale behind doing this sort of combination.
Okay. one last point. Did you notice after surgery in patients who have had neoadjuvant therapy, complete resolution of disease?
Absolutely.
Really?
So not in Proteus, because I can't comment on that because I don't know.
Okay.
But in our phase 2 trials, we had up to 30% of patients have P0s or minimal residual disease, less than 5 millimeters of cancer. And that was, patients that had, D'Amico classification, 95% of the patients had high-risk disease.
Interesting. And that's just ADT or ADT with
That's
enzyme?
ADT, abiraterone, and some form like apalutamide.
Oh, okay.
But
Very
Adam,
intense.
that's not a pathologic complete response. You're
Exactly.
combining those two groups together. So he's asking about pathologic complete
About 10%.
or less.
Okay.
Yeah.
But I want to say one thing here, that is not the standard of care right now.
Yeah.
I
I
would
know,
not
but
do it
it's
on your own. It really, truly may not prove. I think it's going to work, but I've drunk the Kool-Aid.
all right. Thank you.
The other point is, we don't know exactly when you start introducing these androgen receptor inhibitors earlier in the disease process, you don't know how that impacts them, the ones that do recur down the road, when they
Yeah.
don't have that as a
You're losing
naive, they're not
armamentarium.
naive to them anymore.
Yeah.
Yeah. So there's a lot still we need to find out.
All right.
One of the nice things, and we probably have to end then, which in the Enzymet trial, which was really important, which I think you highlighted, or maybe you had, was the drug holiday. So the people that got the combination, not Enzymet.
In the EMBARK trial.
EMBARK trial, that 90% of the patients achieved a PSA of less than 0.2, and then the average time was about 20 months. Median time was 20 months until they went back on therapy. And I think the earlier you give the therapy, the more
longer the
intense,
holiday.
the longer the period of time
Yeah.
the patient's going to be off therapy, even if they end up having to go back on it.
Interesting.
Thank you.
Okay. Thank you all very much.
Thank you.
Have a nice day and good meeting.
Hard.